We are presenting you the case of a 51-year-old female patient with a history of a left-sided L5-S1 discectomy 10 months prior. She presents now to us with a recurrent and residual left lateral thigh and leg pain radiating down into her left foot. Since the previous surgery, she has failed, again, multiple steroid injections and non-surgical treatment. On the MRI scan, you can see the MRI from before her first surgery that shows a far lateral and foraminal left-sided L5-S1 disc herniation with compression of the exiting L5 nerve root. Her neurological exam was intact except for a positive straight leg sign on the left side and numbing of her left foot in an L5 distribution. On these images, you can see the T2 weighted cuts, sagittal on the left side, axial on the right side, demonstrating the foraminal and extraforaminal far lateral L5/S1 disc herniation. On the next T1 weighted image with contrast, you can see the postoperative changes from the first surgery with extensive scar formation along the extraforaminal approach area and discectomy site. You can also see that there is a residual or recurrent foraminal disc herniation still present that is not engulfed in scar tissue. Given these radiographic findings, we felt that a contralateral approach for an over-the-top decompression of the foraminal component of the disc herniation would be an ideal approach because it would avoid extraforaminal scar tissue. Now, the patient was brought to the operating room. Patient was positioned in prone position. The reference array for the intraoperative 3D navigation was placed into the iliac crest on the left side. We use this navigation routinely for lumbar cases using the iliac crest reference. The patient is then covered with sterile drape. The operating room personnel leaves the operating room and an intraoperative CT scan is obtained that is then loaded into the navigation system for intraoperative navigation. The incision was then planned using stereotactic navigation by placing the pointer on the skin, indicating a trajectory that would lead us eventually into the contralateral foramen. A 18mm tubular retractor is then placed on the right side through a small paramedian skin incision with dilators, and the right-sided L5 lamina is exposed as shown here in these sequences. Now we're looking at the transition between the spinous process and the lamina. The next step is that we will start drilling, and as indicated on this cartoon, the drilling starts with a matchstick curve microdrill at the inferior edge of the L5 lamina, right in that intersection between the spinous process and the lamina. Typically, I will place the blunt tip of the drill onto the soft tissue, and then we'll start drilling with the side cutting portion of the drill and start removing the bone of the lamina. This is shown here now. We create a laminotomy and expose the ligamentum flavum very close to the midline. Here you can see now the yellow ligament being exposed. The next step then is to extend the laminotomy cranially to find the insertion of the ligamentum flavum under the bone. In order to achieve that, we remove more bone medially and cranially. We remove the soft tissues. The last millimeters of bone are being removed with a Carrosine rongeurs in order to protect the dura that will be exposed above or cranial to the insertion of the ligament. Now we're using a ball tip nerve hook to lift up and separate the ligamentum flavum from the underlying dura. You can see here that we're removing now the right leaflet of the ligamentum flavum and create a window and opening medially that will allow us then to look over the top towards the other side. Once the ipsilateral laminotomy has been created, the next step will be then to cross over across the midline. In order to achieve this, we tilt the operating room table away from the surgeon and we angle the tubular retractor more laterally to really get access under the spinous process and get access under the contralateral lamina. We now remove more of the ligamentum flavum to expose the contralateral thecal sac, and in order to create a window towards the other foramen. We can use stereotactic 3D navigation to confirm the amount of lateral exposure that we have achieved. Now, in these sequences, you can see that the disc herniation is being visualized and incised. We mobilize the disc herniation with a ball tip retractor and then remove the disc fragment with a small pituitary rongeur. Throughout this procedure, we always protect the dura with the left side with the suction. We then explore further under the PLL to look for further disc fragments to make sure that the exiting and the traversing nerve root are completely decompressed. On this photograph, you can see a nice visualization of the exiting contralateral L5 nerve root on the left side and how that is being visualized and exposed through this contralateral approach. Finally, these sequences here with an intraoperative 3D navigation shot where we merge the preoperative MRI scan with the intraoperative CT scan. These images show and confirm that we've got beautiful contralateral decompression, and we completely decompress the contralateral foramen and decompress the pathology and decompress the exiting L5 and the traversing S1 nerve root. This patient ended up doing very well. She went home the same day, had an excellent pain-free recovery.